Okay. Hello everyone and welcome to today's Australian Centre for Value-Based Healthcare webinar. I'm Emma Hoban, Policy Analyst at the Australian Healthcare and Hospital Association. It's my pleasure to be your host for today. Before we begin, I would first like to acknowledge the traditional owners on the land on which we meet wherever we may be today and pay my respect to elders past and present. I also pay my respects to any Aboriginal and Torres Strait Islander members who are joining us today. Today we are joined by Dr Sidney Chandrasiri, Deputy Chief Medical Officer and Group Director, Academic and Medical Services at Epworth Healthcare. Dr Sidney is a Fellow at the Royal Australian College of Medical Administrators, a Fellow at the Australian College of Health Service Management, graduate of the Australian Institute of Company Directors, and holds a Master's in Health Management and Certificate in Health Informatics. She's also a graduate of the highly selective Harvard Business School Intensive Seminar Program on Value-Based Healthcare, taught by Michael Porter. She's also a Board Director of the Health Code Health Services and a Sentinel Events Reviewer for the Department of Health in Victoria. She has a medical management experience in both public and private healthcare organisations across both Australia and New Zealand, and has lectured in health systems management to postgraduate students at the University of Monash in Melbourne. She's a speaker at multiple medical forums across Australia and has published more than 16 papers in leading medical management journals. Having just returned from discussions with leading experts in the field of value-based healthcare at Boston, San Francisco and Arizona in the United States, her current portfolio in Australia encompasses health service leadership and a number of areas across clinical governance, through to clinical services design and strategic planning. Today, Sidney will be discussing managing the intersection of digital healthcare innovation in value-based healthcare systems. Sidney has kindly agreed to answer questions at the end of the presentation, so if you have any questions during the webinar, you can type them in the Q&A section at the bottom of your Zoom screen, and we will answer them at the end of the presentation. Welcome, Sidney.
Thanks very much, Emma. Good afternoon, everybody, and thank you for joining this webinar. So we're going to be talking about value-based healthcare. Now, no doubt you've all heard of this elusive concept and some of you may even understand it. I know that I'm still trying to get my head around it. So that's what today's session is going to focus on. Now, as Emma mentioned, recently I was selected as one of 4 Australians to attend the Harvard Business School seminar to learn directly from Michael Porter himself on value-based healthcare. And for those of you who aren't familiar with Michael Porter, he is dubbed the father of value-based healthcare. Now, there were more than a dozen other countries represented at this session. And the thing that really struck me was how far ahead other countries were in comparison to Australia in a range of areas to do with value-based healthcare. So that's the purpose of my talk today. It's really to build awareness of what it is and what it can mean for Australia, and to start a conversation about how we can go about implementing it. So firstly, let's look at what it is. In the most basic sense, it's a framework for delivering healthcare in what very well could be a better way to do so. Now, Kaplan described it in the form of an equation, outcomes over cost equals value. But it's interesting to note that it's not just any outcomes and it's not just any costs, it's outcomes that actually matter to patients. And it's the total cost involved in delivering healthcare, not the individual costs of separate components of care service delivery. And that's really important when we look at a full cycle of care, which is what is proposed to bring the greatest value to patients. Now, the Institute of Healthcare Improvement has described value-based healthcare in the form of their triple aim, which is about improving patient experience, improving population health, and reducing the per capita cost of care provision. However, it wasn't until 2006 that Michael Porter and Elizabeth Teisberg really elevated this concept into the global stage with the publishing of their book called Redefining Healthcare. And surmised that the reason that healthcare around the developed world is becoming unsustainable was really because the competition around it and the incentives that we've got for how it's provided are just basically wrong. And that's what they coined as zero-sum competition, which we will explore in more detail over the next slides. So going back to what value-based healthcare is in its most basic concept, it being a model of delivering better healthcare, I just want to emphasize that it's about trying to structure our healthcare services in a way that it's readily aligned to the pace of which medical sciences advances. And it's really about taking a systems view of delivering healthcare. So it's not about doctors or clinicians working harder or longer in isolation or in silos. It's about integrating the different components and different sectors of healthcare that we've got to provide, to take a long-term view and to provide value over a full cycle of care. So to understand zero-sum competition, as Michael Porter put it, we really need to understand how normal markets work. So if we look at the trajectory of healthy competition in a normal market, we see that with increasing demand for a product or a service, there is obviously improvements that have to be made in processes and the methods that take to produce it, which leads to efficiency, which then decreases cost. And the participants in the market obviously have to compete on quality of service, or they have to build a better product in order to meet the demand and stay in competition. And which means that the quality of the end product rises. And this continuous innovation is incentivized by doing this, which means all the participants have come up with new and better approaches of how to do this. And there is faster diffusion of these concepts into the market, which means that the market itself expands. So if you've got a provider who's providing a poor quality product or can't keep up with the competition, they either have to get restructured or they just go out of business. And it's really interesting because in order to understand this concept of zero-sum competition, we have to view healthcare as a market. Now, although healthcare is said to be complex and there's information asymmetry in that, it's said that doctors have more information than patients, so strictly healthcare is not a market. If we don't compete on quality and outcomes, then we're not really incentivizing the various stakeholders in that healthcare market to improve. And if we look at our current healthcare, we're not doing that. We're not competing on quality and outcomes. And anyone can operate in the healthcare market, even if they've got poor quality outcomes, or at least if they reach a bare minimum in terms of standards. And any improvements that need to be made are not incentivized. It's quantity of service provision or quantity of patients treated that is incentivized. And if we look at this concept of a healthy market needing faster diffusion, clinical trials, for example, take, on average about 17 years to become clinical practice. So these are the reasons why healthcare itself is not displaying the concepts of healthy competition. So I'm going to spend a bit of detail on this slide to talk about what the features of zero-sum competition in healthcare are. So if we look at where the competition is structured, it's at the wrong level, in that competition is currently between health services or between hospitals, or it's between health insurers. Hospitals compete for patients, and they do this by providing a broad variety of services. They try to be everything to everyone. Health insurers compete for members, and competition becomes about getting a larger piece of the pie for each participant in the health sector. And competition is currently at the wrong objective, because then the objective becomes about decreasing cost for themselves and not about decreasing the total cost for the healthcare sector. And we see this with provider groups or physician groups consolidating to increase their bargaining power or to increase their purchasing power. Now, while you can gain modest efficiencies by doing this and modest savings, there's really no incentive then for these participants to keep innovating or to increase quality. So their target just becomes to match the lowest standard, or sorry, a bare minimum standard. let's look at in terms of the geographical market. Competition is currently very much locally based. You know, we compete locally with health services within our state or even within metropolitan areas. And what this does is it promotes inequalities in access for rural and remote areas, which is what we're seeing with maldistribution of medical specialists and unwarranted variation in terms of access and provision of services. And these are struggles that we're facing in Australia today because of this feature of a zero-sum competition. If we look at info about, the wrong information. So at the moment, information is very much towards looking at patients or consumers' satisfaction surveys. And whilst patient experience is really important, what matters more is clinical outcomes and the functionality for the patient. I mean, myself, for example, when I go to a hospital, it's great to have a good experience, but I would really rather have a substantial improvement in the outcome, or I would expect to have a better treatment or a better functional outcome out of it, as opposed to just a better patient experience. So I think, so that's really important, that we are currently we're only currently competing to provide a better experience as opposed to better outcomes. We've currently got a market where payers have wrong incentives. And if you look at health funds, for example, they're competing to get members, and there's increasing competition to attract healthy members to try and reduce the risk that they face when they have to pay out for higher complex care needs of other patients. And we see this in the private health industry even now with the youth exodus that's been hailed as the reason why private health insurance is in a debt spiral. And it's, you know, there's calls to review the community rating of private health insurance, for example, to try to shift the cost of providing care from the healthy population to the population that needs healthcare the most. And what this does, though, is that whilst noble in itself and makes sense if you look at just the component of the healthcare sector, all we're doing is just shifting the cost around within the same system. And we're not generating overall value. And then on the other side of this aspect is health insurers shifting costs to providers, which we're seeing across the private health sector today, and even in the public health sector, where unplanned readmissions and hospital-acquired complications are attracting more and more penalty payments and reduced reimbursement rates. And lastly, there's wrong incentives set for providers as well, because as I mentioned earlier, hospitals are trying to expand their service lines in a race to attract more and more patients, because they're incentivized that way to do that, because that attracts more and more money. So the focus becomes on cost-saving measures. I mean, how many of our hospitals are, in a mad race to try and reduce length of stay, for example? And what this inevitably turns into is we see hospitals and departments and clinicians inevitably practicing defensive medicine, because we're trying to decrease our exposure to the financial liability that these incentives provide. So if we think of zero-sum competition as being about competing for a bigger piece of the pie, then positive sum is about competing to bake a bigger pie for everyone. And I know that theoretically that sounds, idealistic, but if we go through these concepts, you will see that there is logic behind this. So starting from the top, the right level of competition, instead of competing between hospitals or competing between insurers, if we all collaborate to compete, to treat better, to prevent disease, and to increase better outcomes for disease conditions themselves, then we could generate value. And what we're doing is we are incentivizing the entire sector to innovate and improve. We can do this, obviously, by changing our objective from just cost-saving measures to improving value. And that means that our objective shifts to from being about saving money to improving quality relative to the amount of money. And we can do this by competing across Australia or across states to develop expertise, to decrease medical errors, to increase efficiency, and to ultimately increase clinical outcomes for everyone. And by having the focus of competition at the right geographic market, meaning that the competition is not just at the local level, but it's across geographical markets, then access improves for people in rural, regional and remote areas. And we also allow more players to enter the market, which then further stimulates growth and innovation and further stimulates the drive for improvement and better quality outcomes. Even construction of hospitals and clinical service planning becomes about delivering services that create unique value to distinct groups of patients instead of us competing with similar providers to try to provide as many services as we can to try to get as many patients as we can. Now, in terms of information, if we shift from just capturing process measures or patient experience measures to a comprehensive range of outcomes, but particularly clinical outcomes that are relevant to patients. Patient-reported outcome measures, as well as the ones that we're already measuring, then it becomes, then we shift the sector into becoming about allowing comparisons between providers, so that patients can be referred to centres based on the highest rate of success for whatever procedure or treatment that they need to have, instead of just the closest, biggest hospital there is. And in terms of creating the right incentives for payers, if we restructure our payment systems to pay for value, we're really looking at this concept of paying for performance or selective contracting between health funds and hospitals, or between governments and public hospitals. And what happens is, the basic concept is that payers essentially reward the providers by referring their members based on the performance of that individual health service, or offering better reimbursement rates. For example, a hospital that has better cardiac outcomes, for example, should have cardiac patients referred to that hospital. They should be getting better reimbursement rates. And those that higher level of reimbursement rates can be then fed back into foster more innovation and further improvement. So, and similarly for the incentives for providers as well, because it's about health services developing areas of excellence and expertise to improve the quality and efficiency of a certain service they provide, as opposed to trying to be everything to everyone. And it's really about meeting and exceeding the bare minimum of standards, instead of just struggling to meet, the current standards that we all strive to meet and thinking that that is good enough. So value-based healthcare, in a nutshell, is about exceeding these standards and redesigning healthcare delivery to generate positive competition for the entire health sector. Now, I hope you would have seen that this means that value creation is obviously not about cost reduction. And value creation is not just about quality improvement either. And the example that I frequently use is hand hygiene compliance. We all measure hand hygiene compliance diligently. And we think that if we've achieved 98% or 99% hand hygiene compliance, that we're doing really well. But I ask you, what is the point of having 100% hand hygiene compliance if that hasn't actually reduced your hospital-acquired infection rates? So that's where the value is. So it's important to note that decreasing unwarranted variation results in value creation. Increasing efficiencies in any part of the healthcare delivery process increase value. But the important thing to remember is that it's not about cost reduction alone. The focus really has to be on reforming outcomes and identifying relevant outcomes for our population groups. So just focusing a little bit on what health outcomes are. As I said, these are about outcomes that matter to patients. They're not about outcomes that matter to hospitals, or the outcomes that matter to health insurers, or the outcomes that matter to governments. It's about outcomes that matter to patients, which in turn will lead to outcomes that matter to all of those stakeholders as well. So it's not so much about looking at process measures, as I said, but about looking at the outcomes. I mean, I know there are several health services that pride themselves, for example, on their door to balloon times, for example. I mean, that's great. And that just what that reflects is it's an improved process that they've got at that health service. But instead, what if we focus on looking at actually reducing mortality rates, or aiming to get the patient to return to work sooner, or improving the patient's quality of life, and actually using that as an indicator to measure our performance against, or to have indicators where, you know, after a certain surgery, patients are able to walk further sooner, or climb more stairs, or they have less pain. Functional outcomes that actually matter to patients. And this is where it's important to go back to that concept of the full cycle of care, because it's not about just the outcomes that you get from providing one intervention or one procedure. It's about the total outcome that you get from involving all segments of the service that is treating that patient's condition. So for example, if you look at a cardiac failure patient or someone who's had a heart attack, the full cycle of care would look at having their diabetes managed and having their hypertension controlled, for example. And that would involve all sectors of the healthcare industry, from, you know, everything from primary care, prevention, screening, right through to the surgery, intervention, and then post-acute care. That's why everybody needs to sort of play a part in this. Now, you know, you might be thinking, where do I even start with coming up with these outcome measures? So there is, most of you may have heard of ICHOM. It's the International Consortium for Health Outcome Measures. Now, what that is a independent group that has come up with standard outcome sets for certain disease conditions that they think matter to patients. And it's been designed by leading clinicians from around the world. And the aim is for that to be used as a framework for health services to work off and to adapt those standardized outcome sets when measuring their services, because that will allow easier and better comparisons and benchmarking later on as well. So if you haven't already done so, I really encourage you all to check out their website. There's a range of standard outcome sets that are still in development, but things like outcomes for osteoarthritis, heart failure, things like that, that's all been done. It's all there, the work's been done for you. So it's about then using that and then adapting it to your local health service. And then just looking at PROM's patient-reported outcome measures, the Australian Commission of Quality and Safety are already have already come up with standard PROM's question indicator sets as well that you can readily use. So, you know, one of the things that I constantly face when I talk about value-based healthcare is this innate resistance to it, saying that, you know, we're already providing valuable care. You know, what is so different about this, and what's the need for it? So let's look at why we may actually need to reconsider our concept and our status quo that we're holding so tightly onto, that we're already providing value-based healthcare, because we may not be. Now, as you would know, across the developed world, health expenditure is becoming increasingly unsustainable. And Australia is obviously one of those. Out-of-pocket costs has recently been topical and continue to be topical. And I don't believe we have found a significant or effective way to address that yet. I mean, sure, we've created, you know, fee transparency websites, and we talk about providing informed financial consent for patients. But if we think back to that zero-sum competition framework that I mentioned, aren't we just shifting the cost or the problem to another participant of the health service? We're not really addressing the problem. Similarly with, you know, penalty payments for readmissions and hospital-acquired complications, as I mentioned, these are increasing. And our health system does not really have strategies to how to deal with this. And there's this constant tension between providers and health insurers about these issues. We've got an increasingly aging population and an increasing burden of chronic disease, not just in Australia, but across the developed world. So these are obviously going to create increasing burdens that I don't believe the way that our current health system is structured is equipped to deal with. And in terms of health inequalities, you would have seen the second iteration of the Atlas of Healthcare Variation that was released by the Commission. Shows that there's significant areas of unwarranted variation across Australia, across geographical areas and across different diagnoses and different treatment modalities, which are creating essentially low value care for some. And access issues. Recently, there was a program around how the level of access or the type of treatment you get depends on the postcode you live in Australia. So these are just the tips of the iceberg in terms of a growing problem that we really need to address. And the Medicare benefit schedule review that is happening now is finding that we've been paying for care that is not always evidence-based. And I do want to just touch on the concept of low value care here, because recently VAHI, the Victorian Agency for Health Information, has put together a list of, I think, about 10 conditions that they've deemed through rigorous research and literature that's been published in the British Medical Journal as being low value, meaning that they don't provide a significant clinical benefit for the cost that they incur. And some of these are things like arthroscopies for osteoarthritis or colonoscopies for the treatment of constipation. Now, it's interesting because I'm sure a lot of our health services are providing these procedures, by the hundreds. But we don't really know how much it's costing us. And we don't know whether it's actually creating any value for us. And more importantly, our current and future clinical service planning at the hospital level or at the government level don't take these into account at the moment. And then in terms of emerging disruptors in the need for value, I highlighted to earlier, is the private health insurance value proposition. And I won't go into too much about that because we did touch on it. And we're seeing increasing changed care models, for example. We're seeing increasing shift from overnight to day surgery. We're seeing hospital in the home care models. We're seeing increased insurers coming into the space of providing rehab in the home, for example. So these are emerging disruptors that are currently incompatible with the way that our system is structured to provide proper valuable care. And then there's increasing digitization with the EMR or EHR, or increasing aspects of telehealth or telemedicine. And these haven't really factored in considerations of value and benefit. Health consumerism is an emerging disruptor in that, increasingly, even in Australia, you can order your medication online, for example, or you can schedule appointments with doctors via apps. So there is this shift towards patients expecting, instant medicine. And I think we haven't got the infrastructure to really support, to sustain all that. And then a big area that I think is facing a lot of health services is the introduction of new technology, particularly, that of robotic surgery or even artificial intelligence. Because currently we do have frameworks and processes where for trying to safely introduce new technology, but these are very much based on looking at the available evidence or literature, which is great, about clinical efficacy, outcomes, side effects, safety profiles, etc. And then in terms of the cost, it's really focuses on the costs being manageable for the health service, or the costs being a driver of further business development for the hospital. But there is no real comparison of value to patients of introducing new technologies, or whatever the technology is, or what its impact on the healthcare sector as a whole is. So if we if we use the framework of generating positive sum competition, what we can do is we can look at some specific strategies of how we can generate value in healthcare in our system today. So instead of being everything to everyone, we need to create unique value. Hospitals need to look at creating services that are treating a segment of the population, or a specific disease condition, or a combination of disease conditions. And we need to compete on our ability to diagnose and our ability or success in treatment and our ability to prevent the disease. And that's where this concept of vertical integration within super specialization centers, or some people call it centers of excellence, comes into it. That's where you are integrating or aligning the preventative care aspects to the acute care or the surgical care, and then the post-acute care of a patient. So you're actually following the patient through and providing care based on a full patient journey for the full cycle of care. And the other aspect of super specialization centers is that what we tend to do is, by doing more procedures or more of the same type of care at a similar center with similar people, you're building expertise and you're increasing efficiencies, which means you're increasing the value. And then there's the other concept of horizontal integration between super specialization centers, which is about having established referral pathways between already established centers of excellence for different aspects of the patient care pathway. Now, I think that it's a little bit complex. I think at this level, for us, it's really about trying to build centers of excellence and looking at reorientating our objective to delivering care that is of value to a patient and not of value to the hospital itself. Another value generating strategy is taking a prevention and population health focus. And the way that this generates value is that by doing so, we're treating the chronic conditions, for example, or subsequent symptoms that require treatment, or and decreasing the high cost of care that a hospital admission or a surgery is likely to have. So in effect, that's how you're generating value in that situation. Looking at care coordination and navigation. Now, this is a huge issue in Australia. Our health system is structured in a way that it's quite complex for a patient to navigate, and continuity of care and follow-up becomes an issue. Patients fall through the cracks in terms of following up with GPs or outpatient appointments, or making sure they're compliant with their medications, etc. So taking a care coordination approach and assisting with navigating the healthcare sector will generate value, and it may even address the issue about out-of-pocket costs, because you can assist the patient with informed financial consent and help them to find the provider that is providing a better outcome for a lower cost. And what it does also is that it improves people's health literacy, and it fosters engagement with the health system as a whole. And this final point about, not final, but one of the points about disinvesting in low value care means actively disinvesting in low value care. And so things like choosing wisely campaigns, which has been rolled out across Australia, is an example of how we can do this. But going further about using that list of 10 procedures that Rahi is going to put out, for example, and looking at could we disinvest in those and reallocate that cost or those resources to delivering care elsewhere that is of better value. So some more value generating strategies we can look at, predictive analytics. So for example, using predictors of disease to better plan targeted care delivery. And an example of this is, for example, in giving antibiotic prophylaxis for newborns at risk of sepsis. You're taking a preventative approach by using technology and using predictive analytic algorithms to get ahead of that. Same with readmission risks. And in terms of readmission risk, it's about looking at, and I think a lot of health services already do this, about designing chronic care plans or follow-up plans for patients who are admitted at high risk, who are identified as being of high risk of readmission. All of these act to generate value. And this concept of integrating the analytics and information that we already have. And this goes back to what I was saying about not just measuring or focusing on performance using compliance measures or process measures, but combining all the different aspects of information, particularly clinical and financial data, to understand where the value is. So this would mean looking at clinical outcomes as well as patient operational aspects like patient flow or theatre utilization or other process measures, and financial data, including the cost of treatment, and integrating it all to get an accurate picture of where the greatest value lies. However, the predictive analytics component and the integrated analytics component obviously requires us to have strong IT infrastructure and to have a transparent data sharing policies, for example, between health services and between health sectors, and building interoperability as well between different programs, because as I'm sure we all know, it's an ongoing frustration that most of our computer programs don't talk to each other. I just want to touch on this financial data component. Now, a lot of health services may think that they're quite advanced in this space, and I think they may be. But from my experience, particularly in the US, what I found is there's a lot of cost weights and approximations being used to calculate the costs of service provision. So the margins that we create, that we come up with, or that we think we know, may actually be gross overestimates or underestimates of what we're actually getting, which could be leading into this increasing unsustainability of health expenditure. So there is this concept called time-driven activity-based costing, which is a costing methodology that is a bit more accurate. And what it does is it looks at every component of the care that's provided, including the exact minutes that a doctor spends with the patient, or the exact minutes that the theatre tech spends doing a certain activity for a certain procedure, and incorporating all of that into an accurate cost for treating that patient. And it's interesting because I've done some of these calculations for some procedure groups, and you find massive disparities between what we thought a procedure was costing us versus what it's actually costing us. Finally, looking at outcome-based payments, and this is around incentivizing a focus on better overall outcomes for the patient and integrating the care delivery. So an example of this is bundled payments, for example, and that's really about, instead of paying for segments of a patient's patient journey or the components of their care, you pay for that full care cycle, which then incentivizes every single care provider that's involved in that patient's journey to work together to deliver the best outcome, because really they're financially motivated to do so. The last two strategies is around value-based pricing strategies. So in Australia, we've got mostly fee for service, and I put it to you that this creates the wrong incentives, because it creates increasing quantity versus increasing quality. We should think about moving towards performance-based contracts or performance-based funding, but the challenge here is to identify the right outcomes, and that we're not just rewarding performance based on process measures or rewarding performance based on measures that are actually not creating a tangible outcome for the patient. Pay-per-care cycle is really another aspect of bundled payments. And then finally, it's about shared accountability and shared responsibility between funders and health providers, and forming partnerships to achieve all of those things that I've got listed on the slide. And what this is about, really shifting that us versus them mentality into all of us together versus a disease condition mentality. So those are some theoretical concepts. Now, if we look at how do we actually implement value-based care models, I think we first have to look at, well, what are the key challenges to doing so? And as I alluded to earlier, there is inherent resistance to change, as I'm sure all of you know, in any aspect of healthcare improvement. So we have to acknowledge that, and we have to find ways to overcome that. And then there's been rhetoric that there isn't enough evidence, or there isn't statistically significant evidence that value-based healthcare concepts work. And then there's increased uncertainty about whether this is actually going to work, or, you know, what's the feasibility of doing this. But I think, look, acknowledging all of those challenges and all of those opinions, it's important to note that there are pockets of areas across Australia where this is, people are starting to realise that this is inevitably the future, and this is one of the ways that I think we can design a better healthcare system. For example, recently the Victorian Clinical Council released an advisory paper for all Victorian health services, both private and public, to start implementing concepts of value-based care models wherever they can. And New South Wales has obviously I think it's called Leading Better Care program, where they explore the actual implementation of value-based care models, and various others across the state as well. So if we look from a broad generic concept, there are certain elements that we need to understand when we're implementing value-based care models in real life. And the first step would be to identify a patient segment, or identify a disease condition or a combination of diseases for which you think that your health service or your group can provide a greater value. And then, so for example, this could be, you know, elderly patients with osteoarthritis, or it could be patients undergoing total knee replacement on an elective capacity, for example, a specific group or segment of the population, just to simplify how we start off doing this. And then the next step is to measure costs, and to be mindful that we're measuring costs accurately. And I would highly advocate the time-driven activity-based costing methodology, because I've used it and I've found found it to be of great benefit. Then we've got to track outcomes. We can use standardized sets like I mentioned that ICHOM has, or the Quality Commission has released, and look at identifying what are the outcomes that are important for patients, and actually designing these outcomes in collaboration with your patients. This concept of, you know, co-designing, because ultimately they're the stakeholders of, they're the key stakeholders in terms of what outcomes matter to them. And then we can look at developing and embedding some of the value generating strategies that I just went through. And then look at aligning incentives, and that includes financial incentives or business incentives, or, you know, whatever else that's going to drive this. And as we get more advanced in implementing this, we can look at integrating between sectors and across geographical areas. But we can start by looking at reducing duplication of service provision within our own health services. Or, you know, if we're working for a group of health services, reducing duplication between sites of our health service. In terms of embedding value-based pricing, bundled payments are a relatively simplistic way of starting off of how to do this. And I would just encourage, you know, everyone to start having conversations with your doctors in terms of getting them engaged in this process, and getting their opinions of where the key challenges are to creating value for patients, and what we can do to help them, to help their patients. And start having conversations with health insurers and payers about how do we negotiate our contracts or our service agreements to actually generate value for the population, or for the patient, or for the health sector in general. And then finally, we can evaluate, use those strategies to feed back into the process to improve it, and to expand it statewide, nationally, or globally. So this topic was focusing on digital innovation and value creation in that. And to do so, because this area is quite broad, I'm going to focus on medical robotics and artificial intelligence specifically. So in terms of robotics and artificial intelligence, this is just an easy way that that I've got in my mind about what robotics is and what artificial intelligence is. So robotics I think of as the Da Vinci surgical system, where, you know, it's an actual thing that does something to the patient, but you're controlling it effectively. Artificial intelligence is actually a lot more advanced, where you know, it fosters decision support. It looks at predicting risk, or providing a certain diagnosis by analyzing features of images, for example, or it looks at motion sensing technology, or it looks at things like predictive analytics or personalized and interactive care. Now, artificial intelligent robots, and I think this is a concept that when everyone says robots in medicine or artificial intelligence in medicine, they automatically come up with is that this is kind of like your benign Terminator type robot in a white coat that's prescribing you medication. And this is where AI, things like AI navigation, like the Meizo robot or Navio Omnibot in orthopedics, for example, are coming into it. And even concepts like virtual reality AI, which are being experimented on which are being trialed in the US. So let's look at the healthcare robotics market. This is a Da Vinci robot. As we know, it's expanding exponentially. It was valued at $5.4 billion globally in 2017. It's probably more by now. It's going to be 11.4 billion by 2025 with a growth rate of almost 13%. The market is primarily cornered by Intuitive Surgical. However, there are new entrants coming in. So we will see this generation of competition. But I think the important thing for us from a value-based lens is that will it be the right type of competition? And I think what we've got to understand is that despite there being limited evidence that robotic surgery provides better outcomes, this market is expanding, whether we like it or not. These are some of the areas that are mostly in use or mostly being done robotically. Robotic prostatectomy has the most evidence in terms of decreased length of stay, decreased blood loss, faster recovery times, etc. However, other areas are also being done in a drive to, from a business driver perspective, as opposed to an evidence-based perspective. So there are benefits in new technology, in technological innovation, including robotic surgery. These are some of them. So because of all of these benefits, technological innovation is useful and it will persist. So it's our responsibility to come up with a structure and ways of factoring that in to how we deliver services from a value-based care perspective. This is why it's important to start evaluating them with a value lens, as opposed to just having the latest toy or latest technology from a reputational perspective, just to bring in more patients, or from a business development perspective. If we quickly look at some of the limitations of robotic surgery, cost is obviously a huge limitation. Mostly consumables is something that I think people often neglect to take into consideration when analyzing surgical procedures, robotic surgical procedures. And there's also a steep learning curve and the opportunity cost that this creates, because we're creating a generation of new surgical trainees who may not be exposed to the same number of learning how to do open surgeries, for example. So what does that mean for when it comes when a robotic procedure fails and they have to step in and do a rescue operation, for example? And in terms of the lack of clinical evidence and cost benefit, it may be that it's the wrong incentives are driving expansion, because robotic surgery does increase the theatre time that's used. It could increase complications, and it's increasingly being used as a business driver in terms of expanding health services. And so do the clinical outcomes that we've just briefly touched on in robotic surgery justify the increased costs? This slide just really looks at 4 different procedures done laparoscopically versus done robotically. And you can see that all of them have a higher cost done robotically. But is that percentage higher cost, which is greater than 13% in every case, does that justify the value that it creates? And not to mention just the direct cost, but the opportunity cost of having potentially losing out on using these extra resources allocated to other procedures that could generate an equal amount of or better outcome. So, as I said, robotic assisted surgery, I think, is here to stay, so can't sort of fight against it. So how do we find the value in it? these are some techniques of doing that. We look at the long-term value, about looking at, quality adjusted survival, quality outcomes versus the cost of using it. We look at economies of scale, so doing more procedures could reduce the length of stay and therefore increase bed capacity, meaning you are capable, you have the capacity to treat more patients, for example. We could look at building centres of excellence, which is one of the value generating strategies that we spoke of. And what that would do is it would create team efficiency, and it could reduce theatre time because you're developing the technical expertise with with an increased amount of volume of procedures that you do, which could then in turn reduce complications. And by doing that, that could create value. And as I mentioned, market competition, where entrants like Trans and Terex, for example, are creating reusable instruments, which would drive down the cost of consumables, which would drive down the cost of instruments that need to be replaced, and it could increase access for increase access for a greater portion of the population to have robotic surgery, because it could bring down the costs. Point of comparison, CMR Surgical, for example, is looking at bundled pricing of robotic surgery and contracting out certain volumes. So all of this could generate value. And then innovation. So things like haptic feedback, and making things smaller and better and faster and less likely to malfunction is obviously going to improve quality. So I just want to show this slide very quickly about the volume and excellence relationship. This was a study, I think, done in 2000, which showed that the mortality rates of low volume hospitals for a range of high-risk procedures or high-risk surgeries were higher than their high volume counterparts. And it's interesting because what this tells us is that better experience, increased volume accumulates level of experience, which fosters learning, which incentivizes innovation, which improves outcomes, lowers costs, and creates value. So going back to the concepts that we spoke of, particularly with digital innovation, how do we begin to start off? I mean, this is really point 2 and 3 about starting to measure the costs and track outcomes. Start measuring the costs of the true costs of your robotic assisted surgeries, for example, and then track the outcomes of those patients using the metrics and the areas that I spoke of. And think about building funder-provider partnerships in delivering bundled payments, whether it includes a robot or not in that patient's surgery. Look at, value-based pricing, the concepts that we went through. And most importantly, start collaborating and involving your doctors and your patients and your other clinicians to come up with better ways to do this by using a value-based healthcare lens. And even though it may be true that there aren't, strict statistical evidence to say that value-based healthcare is exactly better than something else, I think that as we continue to implement these processes and we continue to implement these concepts and continue to evaluate the outcomes of them, that's obviously going to add to our knowledge base. And I think that's going to expand what we can do further. So look, to sort of finish off, I just want to say that I think it's about starting to have a conversation about value at your, with your stakeholders. And so start having a conversation about value at your next health fund contract negotiations, for example, or at your next statement of priority negotiations. And start getting buy-in from your doctors and clinical staff to look at this. And it's really interesting when we look at, in this age of ever increasing digital innovation, we can't lose sight of what the purpose of healthcare is. And Dr. Martin Cohen, who was the chief medical scientist at IBM Watson, really summed it up in his quote where he said, merely proving that you have powerful technology is not enough. Prove to me that it will actually do something useful, that it will make my life better and my patients' lives better. So what this means is that innovation and adopting new technology should be about value, the value for patients, but really, most of all, about providing better care for our patients. So I will end with a quote of my own. Now, I fully acknowledge that all this may seem very daunting and it's an uncertain future that approaches, but I think we must learn to adapt, to innovate, to view things from a new perspective, And this may mean rewriting the status quo or facing great opposition from a great number of stakeholders in the health sector, and even questioning our own thinking. But I think the time is now, and we have what it takes to forge a new path, a better path, a value-based path. But most importantly, we must be doing it together. Thank you.
Thank you very much, Sydney. That was a great presentation. So just a reminder to everyone that Sydney has agreed to answer questions. So if you have any, please go down to the bottom of the screen and type them in the Q&A section. We do have a couple of questions already for you, Sydney. Could you please describe some of the value-based initiatives that you are currently implementing at Epworth Health?
Okay, well, we're very much, much like other health services, we are in the, infancy stages of value-based health concepts. And it's really, as I said, about looking at tracking our outcomes and measuring our costs. And, but one area that I'm particularly keen on is our arthroscopies and our gastroscopies, for example, because I think that there may be area for greater clinical benefit, but not just clinical benefit, but also greater value in terms of having better margins and actually accurately measuring our costs. So that's what we're actually currently looking at actively, starting off with arthroscopies, because a lot of work has been done around that area across the world, and that's what we would start off with.
Great, thanks, Sydney. You talk about so one of the problems is changing attitudes within the health sector. Another issue could be changing attitudes within the public, within patients, as a lot of patients have come to accept kind of high value technology in their care. Can you suggest some strategies that could be implemented of how we would go about reframing the concept of technology for patients?
Yeah, and I think it really goes towards health literacy and, having these conversations, not just with doctors, but patient groups as well, about discussing the value-based healthcare concepts. I mean, and explaining to them, some of the problems we're facing now, like the out-of-pocket costs issues, or like the value proposition of private health insurance, is all related to the concept of perhaps not appreciating the true value-based approach to things. So I think when we're looking at tracking outcomes, or looking at designing value-based models, that part about co-designing with your patients and bringing them along as part of that journey and getting them to appreciate and understand the challenges that the health service is facing, not just individually but across the health sector. I think that would be the way to bring them along with it.
Thanks. Another question for you. What do you think would be the biggest barriers to implementing value-based healthcare within Epworth?
I think that it's multifactorial. I think new technology or digital innovation is a significant barrier in that, and our relationship with the doctors, in that doctors are not, employed practitioners in the private health sector, and that and we have a special relationship with health funds. So those are, I think, challenges that need to be navigated, which is why engagement with the health funds and engagement with our doctors and the buy-in is all the more important, especially in Epworth and other private health institutions, because it needs to be the clinicians that understand the value of this, if you will, and understand the need to lead this and implement it.
Great. Thank you very much for that, Sidney. I think that's probably all we have time for. Oh, I have one more question that we'll squeeze in. Currently, there are significant out-of-pocket costs for people who decide to have robotic surgery over normal surgery. Where is the value for the patient in robotic surgery if health outcomes are not measured by clinicians?
Look, I think the person that said that question has summed up the problem accurately. That exactly is the problem that we're facing. However, some outcomes for some robotic surgeries are being measured. For example, in robotic prostatectomies, we are measuring that there is increasing involvement of external registries, for example, in participating and measuring it. But I think that is the challenge. We have to start measuring it. and we have to start measuring also the accurate costs, so that and be transparent about those outcomes, so that the patients, the GPs that refer patients to us for robotic surgery can have visibility and can be aware of the comparisons in making that decision.
Fantastic. Thank you very much, Sydney. That's been a great presentation today. For our viewers of the webinar, as many of you know, we do have the Australian Centre for Value-Based Healthcare monthly webinars. So our next webinar will be held on Thursday, the 9th of April, and it will be joined by Kaylin Scott, who is the Chief Innovation Officer at Helgeson Solutions Group, a value-based healthcare consulting company in the US. So she'll be joining us from New York to discuss the delivery system reform incentive program and how they are using this to reform the healthcare system and tie value and quality to funding. So if you would like to register for this webinar, you can do so at either the Australian Centre for Value-Based Healthcare website or the AHHA website. Also, if you would like to receive our regular updates on what is happening in the value-based healthcare space, you can sign up to our newsletter on the Australian Centre for Value-Based Healthcare website. So if you want to find out more about these webinars and what else is happening, please sign up for that one. So once again, we would like to thank Dr. Sidney Chandrasiri for her great presentation today. And we hope you all will join us again next time at our next webinar on the 9th of April. Thanks, Sidney.
Thanks, Emma.